Okay, so good evening, everyone. My name is Talah Nammor. I don't know if you guys all know me, but today we're going to discuss diabetes. What do you know about diabetes? I'm pretty sure that you guys have taken this before, even if you did not take it in school or if you didn't take it in uni. You know people around you that might have this disease. So can you tell me, what do you guys think diabetes is? Insulin. Okay, yeah, it is related to insulin. No insulin or insulin resistance. Honestly, that's like you kind of summarized the whole thing. So we all know that we have two different types of diabetes, type 1 and type 2. And the main difference between those is that one has no insulin and the other has insulin resistance. So this answer is perfect, inshallah. Let us start, خلاص. Okay. So diabetes, it's basically a syndrome, all right? It has to do with your hormones. And it basically happens when we have extremely high fasting blood glucose. And this is usually because either we don't have enough insulin, like we don't have insulin at all, or we have insulin, but our body is resistant to this insulin, so it does not allow it to work the way it has to do, all right? It is the leading cause of adult blindness, amputation, and a major cause of renal failure, heart attacks, and strokes. Does anyone know why it might cause all of this? So basically, glucose not entering the cell. Yeah, that is one of the most important things. So basically, the increased amount of glucose in the blood and the decreased amount of glucose entering into the cells will result in basically the cells will not function normally. And this might have a lot of complications. And then guys, later on, you're going to take that diabetes has microvascular complications and macrovascular complications. Now you only have to know that diabetes have complications, and these complications might be like blindness, amputation, renal failure, heart attacks, and strokes. All right. Now we said we have two different diabetes. We have type 1 and type 2. Now, they used to call it insulin dependent and non-insulin dependent diabetes. Like type 1 is insulin dependent and type 2 is non-insulin, but they stopped using it because it's not 100% true. All right. Okay. Does anyone know what is the usual level of fasting blood glucose, the normal level? Okay, so the normal is less than 125. So once we have a blood fasting glucose, exactly from 90 to 125. So if a patient presents to you with a blood glucose that is more than 125, yani 126 and above, then we have to start thinking that the patient might be diabetic. Because obviously we don't like diagnose a patient without repeating the like tests, right? So you can see here that we have basically different ways of diagnosing type 2, even type 1 diabetes, all right? So we mainly have three tests. So the first one, which is the easiest to use, which is the fasting plasma glucose. So for the fasting plasma glucose, we have to ask the patient to fast for before coming for 8 to 12 hours, but not more, because if they fast for more than 12 hours, the body will start basically to produce glucose by breaking down the glycogen. So the glucagon, you know, the glucagon hormone, it will be released, and this glucagon is going to basically stimulate the body to break down glycogen and form glucose. So we have to make sure that the patients only, fast for from 8 to 12 hours. And then it's a simple machine. You're gonna take it in pro, inshallah. You just like prick the skin and then the blood will like ooze out, and then you put it on the scanner, and it gives you the number that yani, the amount of glucose that is in your blood. Now, as you can see in here, it's written that you have to like obtain the fasting plasma glucose on 2 separate occasions. So it's really important to make sure that when a patient comes to you with high blood glucose, you don't directly diagnose them with diabetes, because maybe they lied to you. Maybe they said, okay, I was fasting for the past 8 to 12 hours, but before they entered to your clinic, they ate something that is sweet and that increased their glucose. Or maybe they did not, they weren't aware that they have to only fast from 8 to 12 hours, and they fasted for more, so the body like took matters into its own hands. Okay, so it's really important to basically like measure the blood glucose on more than one occasion. And then we have the 2 other tests. I will start with the oral glucose tolerance test. The oral glucose tolerance test is basically when you give like a patient 75 milligrams of glucose, all right? Like you give them, let's say, a piece of chocolate, anything, but usually it's not like that. They usually like dissolve the glucose in water and they ask the patient to take it. And then they test the glucose, first of all, an hour after and then 2 hours after, all right? So usually after ingestion of glucose by 2 hours, we have to have a decrease in the blood glucose level, all right? So in here, as you can see, if we have like a blood glucose that is more than 200, all right, then this is kind of like scary, because this might mean that the patient has diabetes, all right? And then lastly, we have the hemoglobin A1C. Can someone I think my Wi-Fi cut off. I'm really sorry, guys. Um, can you hear me?
Yes.
Okay, you can see the screen, right?
Yeah.
Okay, I'm sorry again. I don't know why did I cut off. Anyways, so in here, back to it's recording, right? Yeah. Okay. So back to the hemoglobin A1C. What happens is, because of the increased amount of glucose in the blood, and you know hemoglobin is always there, it's literally what makes up blood. What happens is that the hemoglobin is going to get glycosylated, or basically a glucose is going to be added into the structure of the hemoglobin. And it's really important to know that basically hemoglobin A1C, this level that you see, like if you test it, it's going to last for 3 months. So it's mainly used to basically like check if a patient is, if we know that a patient is diabetic, and we just want to check if this patient is responding to treatment or not, or if they're compliant to the treatment or not. Because basically it's the same, it will stay like, مثلا, let's say it was elevated the day the patient came in, and it was, let's say, more than 6.5%, as we can see here. Then after 3 months, it will stay the same level until طبعا يصير عندنا turnover of hemoglobin. I'm pretty sure you guys just finished HLS, so you understand like how basically hemoglobin like lasts for like the RBC itself, it lasts for 3 months, and that's why like the hemoglobin is going to stay, or I don't think it's the RBC itself, but yani, the hemoglobin is going to be recycled and so on. So just know that this level is going to stay the same. So it's mainly used for to check if the treatment is going well or not. All right. So do you have any questions till now, guys? Did I overwhelm you with stuff? Well, that's pretty easy. Did I cut off again? Okay, good. Okay, so it's pretty easy. I don't know if this lecture like covered it a lot, but I don't think it did. So we have something called pre-diabetes, and you can see it in here. So the pre-diabetes is just like, you know, when a patient has a lot of risk factors, like let's say a patient is, let's say he's obese, he has like a family history of diabetes, he is not physically active, he already has hypertension and other like a lot of diseases. So most of the time they're going to be in a place where they're pre-diabetic, and we can clearly see that in in the tests in here. So basically, if you مثلا take a fasting plasma glucose of a pre-diabetic patient, it's going to be between, let's say, 120. No, it's in here. It's usually between like let's not talk about this plus, never mind. But usually I remember it's between 126 and 140. But maybe it's less. Usually, no, sorry. Usually it's from 109 to 126. This is pre-diabetic. And then once they're 126, this is 100% diabetes. All right? Did I confuse you a bit here? It's not important. I don't think the doctor like mentioned it a lot. But saying it's just general knowledge. So basically, like a small cutoff before, like we know that if it's more than 126, or if it is 126, then it's diabetes. Then we have like if it's 110 to 125, this is pre-diabetes. So whoever is in this range is basically in the danger zone, because you're gonna, if you don't change your lifestyle, you're gonna become a diabetic, right? So just this is just like for your information. Okay, let's move on. So in here, they're explaining what is it called? They're explaining the hemoglobin, the A1C, as we said. It's glycated hemoglobin, and it's usually proportional to the average blood glucose over the previous 3 months. So you see, it usually measures how well a treatment has normalized the blood glucose in the diabetic over a period of time. So I think this is pretty clear. I explained that. Do you guys want me to say anything in here more? So you can see in here the glucose, it will attach to the like erythrocytes or that contain the hemoglobin, and then it's going to be glycated for like the rest of its life, which is basically 3 months. Tamam? Shall I move on? Okay, good. Tamam. Now in here, they're just telling you that it's important to basically do this blood tests, and because we have a lot of symptoms of diabetes. Without cheating, can someone give me like a couple of symptoms of diabetes that you know? You can open the mic and speak, or you can send me on the chat. بس يعني, when someone has diabetes, what's the first thing that comes to your mind in regards of symptoms? Like how would they come to the clinic? Hyperdumpsia. Frequent urination, I forgot the name. Okay, so that's correct. Polydipsia, or basically frequent thirst. So they're very thirsty. And frequent urination, so we have polyuria. All right. So if someone can you guys think of a reason of why do we have these symptoms? Like we all know that okay, diabetes is increased glucose, but you all are as well taking renal now. So you know that basically if we have a lot of glucose in our body, and if we basically excrete this glucose in the urine, what happens is, the glucose is gonna attach to the water, and it will take the water with it because it's just like sodium. And you know how if sodium leaves, water leaves. So the same thing happens. We're gonna have frequent urination because of the huge amounts of glucose that are in our bloodstream, and they're not entering into the cells. They're not doing the job they have to do. So what happens is we're gonna have frequent urination. The patient is gonna be thirsty all the time because basically we're losing a lot of fluids by the frequent urination. The patient will be always hungry too. Can someone explain why would the patient be always hungry? طبعا like continuous hunger is called polyphagia. Does anyone have like any idea? Like just think of like, okay, diabetes is sugar. Why would the patient be hungry? Okay, so I'm not receiving any answers, so I'll just explain it. So basically, because we have a lot of sugar in our blood, and this sugar is not entering the cell itself, the cells are deprived from energy. They don't have ATP. So technically, your body is being super deprived. Like your cells, they're being deprived of energy. You're gonna be lethargic or very tired because technically your cells are not getting fed. So you're gonna feel extreme hunger because your body needs energy and it's not getting the energy it needs. So it will keep on asking for more and more. But even if you eat more, it's not going to help because the main issue is that you can't get glucose into the cells. Right? Is this clear? Okay. Next. So in here we said we have frequent urination, excessive thirst, we have thirst, increased hunger, weight loss. So, and why do we have weight loss? As we said, basically the patient is not, we don't have like, okay, we have sugar in the blood, but we don't have any energy source for the cells. So the body will start basically breaking down the fat, it will start breaking down protein. So protein as in like the muscles. So just to gain energy, and this will result in weight loss. And then we have extreme fatigue, blurry vision, slow healing of wounds because again, the body is deprived of energy, and tingling or numbness and so on. I don't think you guys have to know everything, any all of these, just for general knowledge. Okay, so let's review. Can someone tell me what does insulin do? You guys took the lecture and you have to know.
Decrease the glucose level in the blood.
Excellent. And do you know how does it do that? Like, do you know the exact mechanism?
By open the channels of the glucose so the glucose can enter the cells.
Okay, perfect. Now what happens is that insulin, when it goes into the cell, it will stimulate the production of a transporter, which we can see here, GLUT4. This is, guys, very important. So it will cause it will affect the nucleus, and the nucleus is going to send basically signals, and yalla start making this transporter, which is GLUT4. Now GLUT4, it allows the entry of glucose without anything. Like خلاص, once GLUT4 is there, the glucose is going to enter. So for each insulin, okay, like let's say one insulin molecule is going to allow one glucose molecule to enter to the cell, right? Now this information is very important. Keep this in mind. In a normal human being, like a healthy human being, each insulin molecule is going to allow the entry of one glucose molecule, all right? All right. So insulin, it doesn't only increase the glucose uptake, but as well as it decreases the production of glucose through the inhibition of glucogenolysis and gluconeogenesis in the liver. So glycogenolysis is basically the the breakdown of glycogen, and gluconeogenesis is basically formation of glucose from scratch, right? And then it increases glycogen synthesis. And it does make sense if you guys think of it. We have a lot of glucose. We want to get rid of it. What do? We stimulate the body to basically form glycogen, okay? as well as we don't want more glucose to go into the blood. So we're going to inhibit the glycogen from breaking down and the gluconeogenesis from occurring, or the production of new glucose. All right? Is this good? I think it's pretty clear, right? Sorry. Now, insulin as well, it inactivates hormone-sensitive lipase, so it decreases lipolysis. And it activates lipoprotein lipase, therefore it increases the triacylglyceride synthesis in the adipocytes. So, can someone explain what does that mean? Like I said a bunch of complicated words. Can someone just tell me 2 words? Like, what does insulin do in regards of fat? Promotes synthesis. Exactly. So what happens is, we have a lot of glucose. We want to get rid of it. So we don't want, like, if we have lipolysis or if we have breakdown of fat, this is going to increase the energy. It's going to result in, it will help in the formation of glucose. So we don't want that. So what happens is insulin will prevent lipolysis by inactivating hormone sensitive lipase, and it will promote the formation of fat by basically activating lipoprotein lipase. Okay? Tamam? Okay, moving on. Now let's start with the type 1 diabetes. Okay. I said at the beginning, we have 2 different types of diabetes. Now I want you guys to concentrate. No, type 1 diabetes, it is an autoimmune disorder. When we say autoimmune disorder, what do we mean? We mean that basically our immune system will malfunction, like it will suddenly stop recognizing our own cells. Like, you know how each cell has like a receptor where it says like, this is self, like, okay, this is me, like I am your cell, okay? So what happens in autoimmune disorders, the body stops recognizing that, oh, this cell is like part of us, and they will start attacking it. So in this case, what happens is that most of the time, okay, like the normal pathogenesis or the normal, let's say, progression of the disease, usually a patient is going to have like a viral infection, right? So they will have, let's say, because they're just going to have basically an infection that is caused by a virus. I'm not going to give virus names. And then once they have this viral infection, it will kind of like make the immune system malfunction, and this will trigger the attack, where basically our body will start attacking our own like pancreatic cells, which are the B cells. So now we know under the pancreas, it is basically an endocrine and an exocrine what is it called, organ. Inshallah, you're going to take this next year in endorepro. So it has like a bunch of cells. So it's important to know that the B cells, or the beta cells, they are responsible for the formation of insulin, okay? So what happens is our body is going to start attacking the beta cells, and this will result in the depletion of beta cells. And then this usually happens in very young children, like not very young, but it happens below the age of 20. So usually you're gonna have like a patient that is pretty young that has the first onset of type 1 diabetes, while in type 2 diabetes it's the total opposite, where basically we have like older patients. All right, this is important detail to note. So مثلا, if you're reading a question and you see like, okay, the patient is, let's say, 15 years old, then you can directly think, oh, it's type 1 diabetes 100%. But then you see مثلا the patient is like 40, or like usually in like the literature says, basically a patient that is above 40 years old is more like prone to have type 2 diabetes, okay? But now recently with with a lot of like the fast food restaurants and all of these, the type 2 diabetes is starting to show up at a very early age, which is basically 20. But this is an important trick for you guys to know. Yani type 1 diabetes, we look at the age, it's less than 20, then 100% type 1. A patient more than 20 years old, then it's type 2. Okay? Okay. Now, this sentence is quite important. Wait, did I do? Okay. This sentence is really important. اللي هي إنه symptoms will not appear, or they will appear suddenly when 80 to 90% of beta cells are destroyed. So basically a patient, like مثلا a patient will get a viral infection, let's say when he was like 7 years old, and maybe it might take the whole year to basically fully develop type 1 diabetes or the symptoms of type 1 diabetes, because the symptoms will not basically appear until we have totally no more beta cells and we don't have insulin anymore. Okay, so once we have insulin insufficiency, okay, or basically the insulin is no longer being produced, that's when the what is it called, the symptoms will appear. And because we have like the main issue in here is that the beta cells are dying and they're not producing insulin, the main therapy for this disorder is insulin. So we give them insulin so to protect them from, as you can see here, prevent them from life-threatening ketoacidosis. Okay? Is everything clear by now? Well, do you have anything that you want to guys like? Is it okay? Okay, good. This slide just basically like summarizes what I said. So first of all, we're gonna have an initiating event, and it's mainly most of the time you're gonna take in 3rd year. It's a viral infection, and then the autoimmune system is gonna get like, it's gonna start, I don't know, like crumbling, and we're gonna have basically beta cell destruction, and the immune system is going to start and literally like killing the cells. And as you can see, guys, I wanted to say that, but it takes like 10 years to develop like type 1 diabetes, because from the initiating event. So let's say you got a viral infection when you were like 10 years old, or let's say 9 years old, you're gonna get diabetes by 19 years old. Why? Because it takes like time for the body to totally kill the cells. Okay, so type 1 diabetes will only manifest if, what's the percentage that I told you guys? It will only manifest, like we're only gonna start having symptoms when how much of the beta cells are destroyed? Exactly, 80 to 90%. Once 80 to 90% of the thing is destroyed, then خلاص, we're gonna have the symptoms. Okay. Now, you see, as we can see here, it requires both stimulus from the environment, genetic determinant that allows the beta cells to be recognized as non-self. So both type 1 and type 2 are like related to genetics, okay? But type 1 is not that strongly related to genetics, like you see in here, type 2 diabetes, the genetic influence is way stronger than type 1 diabetes. Like, okay, we're not saying that the genetics do not have a play in this, like they do. We have we need, it's always any disease, we have genetics and environment, and both of them will contribute in a way. But in diabetes, type 2 diabetes, we have the genetic influence is way stronger. If a patient comes to you and he has his parents have a history, like the 1st degree family, which is usually the parents, they have diabetes, you're not going to be scared of type 1 as much as you're going to be scared of type 2, all right? Because type 2 is more genetically influenced. Hello? Is this clear? I think it's pretty easy صراحة. Oh wait, okay. So the onset, as I said, it's usually childhood or puberty. The cutoff is 20 years old. Okay, if he's lower than 20 years old, then خلاص, it's type 1. More than 20 years old, type 2. They in type 1 diabetes, they're more consistent with the usual, like you know how we said polyuria, polydipsia, or polyphagia. هدول they are like the three P's of diabetes. طبعا it's kind of funny, three P's of diabetes. Anyways, so basically those three, they're more commonly found in patients of type 1 diabetes. Like those symptoms, if you find them, you directly think of type 1 diabetes because they're more common in type 1 diabetes. هلا those are found in type 2 كمان بس at a very like lower like incidence, okay? And then we have fatigue, weight loss, weakness, and I explained all of these guys. Like polyuria, polydipsia is because of the glucose. We have a lot of glucose in the blood. It's going to be excreted in the urine. It's going to take a lot of water. So the dehydration is going to cause excessive thrust. Polyuria because of the glucose that is being excreted, and polyphagia because basically your cells are deprived from energy and it thinks that we need more energy, so we need more food. Fatigue, weight loss, and weakness كمان from the same idea اللي هو إنه cells they're not receiving like glucose into them, so they're not what is it called, functioning properly. And the diagnosis, as we mentioned earlier, if we have fasting blood glucose more than 126 or equal to 126, then this might be like make us suspicious of diabetes, and the same for hemoglobin concentration more than or equal to 6.5%. Okay. هلا did you understand like the whole idea, like إنه مثلا type 1 diabetes beta cells they're dying. Because they're dying, no insulin is being produced. Insulin usually it goes and binds to the cell and allows GLUT4 to be there to allow glucose to enter. So if we don't have insulin, glucose will not enter the cells. The cells will be deprived of energy, and then we're going to have all of these symptoms. Okay? Am I going too fast? Or is it all right? Okay, good. Now, in here, we're explaining literally the symptoms and I think I mentioned it like before. So when blood glucose is more than 180, the SGLT that are found in the kidneys, they will take the glucose, okay? Oh, wait. So basically, you know, guys, how you're taking renal right now. So I'm pretty sure you guys know. You know how in the kidneys we have the sodium-dependent glucose transporters. So usually they prevent glucose from being in the urine. Like a normal human being or a healthy human being. I don't know why do I keep saying normal. Anyways, a healthy like adult or a patient, they usually our body will prevent glucose from going into the urine. And this is usually done by the sodium dependent glucose transporter. But when the blood glucose is very extremely high, okay, this like the transporter is going to malfunction and خلاص glucose is going to be secreted. Once glucose is secreted into the kidney, water will follow, and then we're going to have dehydration, which will cause increased increased thirst, and we're going to have basically polyuria because of the like increased glucose. As we said, the weight loss is seen in type 1 diabetes because the need of the liver for gluconeogenic precursors. What does this mean? Gluconeogenic precursors. This means because we don't have the glucose is not entering into the liver, the glucose is not entering to the cells, so the body is gonna like it's gonna be like a huge mess. And then what happens is to control this mess, they will start to basically break down fat and break down protein so that we can take basically the ketones and we can take the what is it called? And we can take the like the proteins, and those will help us form a new glucose cells. Okay? طبعا this will not help because even if they formed glucose, we still cannot take it into the cell. But the body does not know إنه إحنا we can't take it into the cell. The body thinks إنه we don't have glucose. Okay? Shall I move on? Next. Okay. Now this slide is very important, and I want you guys to like really, really concentrate with me. So we said that we don't have enough insulin in the body, right? Right. We said that the glucose is all over the place. We have glucose in the blood, but it's not entering the cells. So what happens is the most common presentation of type 1 diabetes patients is ketoacidosis, okay? And you guys can see this here, ketoacidosis. So what happens is we have something called diabetic ketoacidosis, okay? So diabetic ketoacidosis is when, okay, so diabetic ketoacidosis is when we have increased formation of ketones by the body. What are ketones? Ketones are basically, so we said that the body is reaching like the pits. We don't have glucose, it needs energy. So it will start breaking down like fat, and then it will result in the formation of ketones, okay? So these ketones, they're not that good for the body because we're not going to have like increased ketones in a way that is fine. No, we're going to have like a lot of ketones, and this is going to result in the formation of ketoacidosis, or we're going to have like, you know how you guys are taking right now in renal like metabolic acidosis? Have you taken this yet or not? Did you guys take metabolic acidosis? No? Yes? Yes, exactly, in renal. So what happens is ketoacidosis, or the increased amount of, like we have a lot of ketones, it's going to result in metabolic acidosis. And metabolic acidosis is like horrible for the body. That's why it will cause like a lot of other symptoms. So in here, you can see that hyperglycemia is usually caused by the increased formation of glucose by gluconeogenesis, and because we don't have, like we're not using the glucose that is already in the body, okay? Is this clear? Now we'll mention diabetic ketoacidosis more in details in the next slide, I think. Yeah, here, okay. In here, we're just saying that what is promoting the formation of more glucose is the idea that basically when we have a lot of glucose in the blood and no glucose is entering the cell, what happens is this will promote gluconeogenesis, okay? And we're gonna have basically, they will slow the citric acid cycle, and then we're gonna have a lot of conversion of acetyl-CoA to acetoacetate. And we all know that acetoacetate is a ketone, right? Do you guys agree? I'm pretty sure you guys took ketones before, right? Okay, I think, yeah, you did. Anyways, so acetyl-CoA, it will be changed into acetoacetate, which is a non-ketone, all right? And this will cause the increase of formation of, what is it called? This will cause the increased risk of forming ketoacidosis, all right? All right. Now, in here, we're talking about diabetic ketoacidosis, okay? So in diabetic ketoacidosis, as I mentioned before, ketosis is basically increased mobilization of fatty acids from the adipose tissue, or as I said, ketosis is the formation of ketones. And diabetic ketoacidosis is the most common symptom of newly diagnosed type 1 diabetes patients because they will come with the like symptoms of diabetic ketoacidosis. I don't think Dr. Hannah like mentioned what are the, yeah, she did not mention what are the symptoms of diabetic ketoacidosis, but just know and know we're going to have increased ketones and this will result in metabolic acidosis. No need to know the symptoms since she did not mention them, but it's important, as I said, you know, type 1 diabetes patients, they're going to present mainly with what is it called? DKA, okay? Now, the excess fatty acids that we have, because I'm telling you, like we're mobilizing the fat is being broken down, and we have a lot of fatty acids. Those fatty acids, they're converted to triacylglycerol, and then they'll become very low density lipoprotein. Okay. And we said basically that insulin usually it prevents, um, exactly. You see in here we have synthesis of this enzyme is decreased when insulin levels are low. So when insulin is high, when we have insulin, normally it will prevent the breakdown of fat, and rather it will cause the formation of what is it called? The formation of triacylglycerol. So when we're breaking down, so when we have a lot of VLDL and the lipoprotein lipase is not active and it's very low because of decreased insulin levels, what will happen is we're going to have hypertriacylglycerolemia, or we're going to have huge amounts of fat in the body, especially in the blood. Is this clear? Okay. So in here, the doctor just showed you how everything happens in type 1 diabetes. So we can see that basically glycogen is being broken down, okay, because basically we don't have glucose. So our body is trying to like break down all the glycogen we have. And then we're going to have the formation of glucose, but this glucose is not going to be entering any of the cells. So we're going to have hyperglycemia. And then because it's not entering into the cell, the body will think that, oh, it's not working. No, no, no. So we're going to have a lot. So it will start the lipolysis, because aslan kaman we don't have insulin. So it's not going to prevent lipolysis. So we're going to have a lot of fatty acids in the blood. And those increased amount of fatty acids, they will basically result in the formation of ketone bodies, and then the ketone bodies will result in ketoacidosis. All right? And the VLDL and chylomicrons, they're going to basically accumulate because we don't have the lipoprotein lipase, and this will result in hypertriacylglyceremia. Okay? And because we said type 1 diabetes, the main issue is that we don't have insulin. What happens is the treatment is just insulin. So the patients will be on lifelong insulin supply. We have a lot of ways of injecting insulin. It can be directly into the IV, or it can be because of what is it called? It can be like a machine, and so on. Okay, that's for T1D. Yeah, it's only for type 1 diabetes, because basically in type 2 diabetes, we do have insulin, but the body is resistant to it. All right, we're going to go to it now, inshallah. So when we prescribe a patient insulin, okay, the main thing we have to worry about is hypoglycemia. Like, you know how, like if we inject insulin into the body, what happens is that the glucose is going to gush into the cells. Hello? So the cells will be full of glucose, okay? Now, because the cells are full of glucose, what happens is, and maybe now we're gonna exceed this, and we're gonna make it so bad that we're gonna have hypoglycemia, we're gonna have glucose at a very lower level. So what happens is we have to educate the patient properly about the use of insulin, and we have to make sure that if a patient develops hypoglycemia, and directly to take like a sweet thing to improve their, what is it called? To improve their like blood glucose, all right? هلا طبعا usually patients who like hypoglycemia usually happens when, like, how do we know that a patient has hypoglycemia? They start to have palpitations and they'll become jittery. Like the patients who have type 1 diabetes, they they'll understand, like they like suddenly they're gonna have palpitations, they'll be like, oh yeah, maybe I'm going through hypoglycemia. So they directly go get something sweet. Okay. Yani, it's just that we have to educate the patient when like at the very beginning when they start taking insulin, we have to like educate them about this complication, and then they can like control it and so on. So I'm done with type 1 diabetes. Do you have guys any questions? طبعا I technically only have one person here. um we can stop the recording for like 5 minutes. Wait. Wait 1 second. Okay, so هلا. Okay, now we're gonna talk about type 2 diabetes. Hello? So type 2 diabetes, it's way different than type 1 diabetes. بالفكرة إنه type 2 diabetes, the main cause is that, okay, our body is perfect, like it's producing insulin, but our body is resistant to the insulin. You remember how at the beginning of this lecture I said no, each insulin will allow one glucose molecule to enter into the cell. So this is in a healthy human being. But if a patient has type 2 diabetes, what happens is we're going to have insulin resistance, which means one insulin molecule is not going to allow the entry of one glucose. It's going to require 2, 3, 4 insulin molecules to allow the entry of only one. Okay? فطبعا this is going to really cause the beta cells to like get overworked, because imagine انت as a beta cell you're going to produce insulin, but if you produce, let's say, 20 insulin molecules, they're not going to do the job, but you need to produce more and more and more, but this will eventually lead to dysfunctional beta cells. So what happens is, how this type 2 diabetes like happen, أول شيء بصير عندنا insulin resistance. Okay, so it starts with insulin resistance, where basically our body is resistant to the amount of insulin. يعني one insulin molecule no longer allows the entry of one glucose molecule. بالعكس, we need 1, 2, 3, 4 insulin molecules to allow only the entry of one glucose. So this will cause the beta cells in real life, you have to work more and more and more, secrete more and more insulin. And eventually beta cells at the beginning won't mind, وعادي, they'll work everything, but they'll reach a point where it's not bearable anymore, and then we're gonna have dysfunctional beta. Okay. You can see in here that type 2 diabetes, it does not require insulin because the patient is producing insulin, but the body is not responding to the insulin. So there is no point of like injecting a person with insulin as into your body is not responding to it. So we don't treat it with insulin, and this is a very important point, because this is like, when a patient come in with diabetes, you have to make sure and oh yeah, this patient is type 1 or type 2, because in type 1 insulin like literally solves the whole issue, but in type 2 it does not do anything. Hello. هلا metabolic alterations is observed in type 2 diabetes, and they're usually milder than those described for type 1 diabetes. So in type 2 we don't have ketoacidosis. Why? Because as I said, insulin is there, glucose is being absorbed at a certain level. يعني the body is not completely deprived of glucose. So ما حيصير عندنا ketoacidosis. ما حيصير عندنا the whole thing where we have to basically cause fatty acids to be, fatty acids to become ketones and ketones and so on. Ilhad will not happen in type 2 diabetes. It can happen in very severe, like super severe cases of type 2 diabetes, but the normal type 2 diabetes of a patient that presents to us like مثلا they have type 2 diabetes recently, they're not going to have this. All right. And as you can see here, insulin secretion, we have insulin secretion in type 2 diabetes, it's just that it's inadequate. And yeah, it's not going to cause diabetic. Diagnosis, it's literally the same as what is it called? It's literally the same as the type 1 diabetes, a fasting blood sugar that is more than 126 or equal to 126, and like the rest اللي هو إنه oral glucose test percentage more than 200, like all the criteria that we discussed in the beginning. Okay. هلا شفتوا هون كيف they're saying fasting blood glucose of 100 to 125 is categorized as an impaired fasting blood glucose. This range in here is basically the pre-diabetic range, and the pre-diabetic range, especially in type 2 diabetes, is extremely dangerous, because if you are a patient with a high susceptibility to develop type 2 diabetes, specifically if مثلا it runs in the family, if your mother has diabetes, your grandma has diabetes, and so on, then if you're in the pre-diabetic stage, then you're literally in like the most dangerous zone ever. Now, when we identify a patient as pre-diabetic, we start counseling the patient and we ask them like, okay, please, you have to مثلا, look at what you eat. You have to basically exercise. If you're obese, you have to decrease your weight. If you are inactive, you have to have more activity and so on. Because if they do not do those changes, they'll eventually like have type 2 diabetes, all right? And you can see in here how it says, can type 2 diabetes be exactly, type 2 diabetes can be preventable. It can be preventable by life changes. Like if you have all the risk factors, what are the usual risk factors? The most important risk factor is basically having a first degree what is it called, first degree family member with diabetes. And the first degree like family members are usually your parents. So if you have a parent that has type 1 diabetes, then type 2 diabetes, then you start becoming in the danger zone because you are highly susceptible to becoming a diabetic. Okay, but what happens is, you look at all the things that predisposes you. If you have hypertension, you have to control your hypertension. If you are obese, you have to basically decrease your weight. If you have physical inactivity, you have to be more active. You have to make sure what you're eating is not full of saturated fats and so on. Like if you are in the pre-diabetic stage and you started taking action, you can prevent diabetes. But once you're a diabetic, you can't go back. It's really important as physicians, when we have a patient in a pre-diabetic stage, it's super important to basically educate the patient and to counsel them and to show them how they're at a stage which is really, really important, because they can literally save themselves from all the different complications and all of the issues that come with diabetes. Because at the end of the lecture, you're going to see the complications, and inshallah next year and the year after, you're going to learn the diabetic complications in more details, and then you realize, like if I can just prevent all of this by just doing a little bit of lifestyle modifications, then you get me, like prevention is better than cure. But so as we said, type 2 diabetes, the pathogenesis, it does not involve viruses. So it's not autoimmune. This is very important. Type 1 diabetes, autoimmune. Your immune system is malfunctioning وخلاص قرر to attack your beta cells. But type 2 diabetes, it doesn't have to do anything with a viral infection or an autoimmune autoimmune reaction. What happens is we have insulin resistance because of the obesity, because of let's say hypertension, whatever risk factors you have, you're going to develop insulin resistance. And this insulin resistance is going to basically literally it was going to overwork your beta cells until they reach a level where they're like, "Khalas, I give up," and they just dysfunction and die. Okay. Now, an acute complication of type 2 diabetes in the elderly is a hyperosmolar hyperglycemic state. Hello? Now, hyperosmolar hyperglycemic state, I don't want to confuse you guys, but it's literally it's the same symptoms as diabetic ketoacidosis. You don't take the symptoms, but I'll tell you what the symptoms usually are. So basically, a patient that went through a diabetic ketoacidosis crisis, or that is going through hyperosmolar hyperglycemic state, they will come to you with an altered mental status. So they're not going to be aware. They're going to be they'll be aware, but they'll be confused. Okay, they're going to be confused. They're going to basically breathe in a very weird way, where they're going to breathe very rapid breaths, بتنفسوا very, very rapidly, but they're not shallow. They're not tachypnic, or basically they're just breathing very, very fastly. No, they're not hyperventilating. They're just breathing fastly, but deeply. Okay. Now this is all because of the metabolic acidosis, and they're gonna have very dry skin. They're gonna be very dehydrated and so on. فهدول symptoms, okay, they're the same for diabetic ketoacidosis in type 1 diabetes and hyperosmolar hyperglycemic state in type 2 diabetes. Okay? Is this clear? Or did I guys confuse you? Yes, good. If you see a patient, خصوصي بالexam, if you see a patient that came in with altered mental status, Like put in your mind DKA or hyperosmolar hyperglycemic state. Okay, and in here we're saying basically how does it happen? Insulin resistance because of basically mainly insulin resistance is caused by obesity. Like this is the huge thing that is linked to insulin resistance. But it can be caused by a lot of things. So the high would be like the liver, and the liver will increase the glucose levels, and then the pancreas is releasing insulin, but the insulin is not allowing the glucose to enter because we need more than one insulin. Okay, and I think it's kind of because. So insulin resistance. In insulin resistance, we're going to have increased gluconeogenesis. Why? Because again, glucose is not entering to the cells, like not fully entering. And insulin is not entering to the liver command, but it's entering to the liver, but it's not working enough. So what happens is we're going to have hepatic gluconeogenesis. We're going to have free fatty acids again, but they're not going to form ketones. Okay. And decreased glucose uptake. I think this is clear, right? Like literally the same. In diabetes, in both ways, it will cause increased hepatic gluconeogenesis and increased free fatty acids. Tamam? And you can see here, in obesity is the most, is mostly like the most common cause of insulin resistance. Okay, so insulin resistance, as we mentioned before, decreased ability to respond properly to circulating concentrations of insulin. So this will result in uncontrolled hepatic glucose production because the insulin is not it's not working properly. And we're going to have decreased glucose uptake, and we're going to have increased adipose lipolysis. This is literally the same as the type 1 diabetes. Like it causes, like at a biochemical base, we can see that in both we have gluconeogenesis, we have increased lipolysis, and we have decreased glucose uptake. Okay. You see هون عنا what is it called? The risk factors for insulin resistance: being old, people who are obese, they're physically inactive, and usually 3 to 5% of pregnant women, they will develop gestational diabetes. And I think we have a slide about gestational diabetes. Gestational diabetes is just that diabetes that come with pregnancy. That's all. هي الفكرة تبعتها. Now, insulin resistance. Insulin resistance, it increases with weight gain, as we said, and it increases with obesity. And what happens is, it will cause changes in adipose secretions. Okay, let's explain this. So, هلا نحن عندنا something called adipokines. Okay, adipokines are cytokines that are released by adipose tissue. هلا عندنا نحن usually we have like anti-inflammatory and pro-inflammatory. Okay. The pro-inflammatory is what will cause basically a disease because it's like stimulating an inflammatory response, or basically a bad response. While anti-inflammatory, it prevents this. And in a healthy human being, adipose tissue is going to release the anti-inflammatory adipokines, اللي هن basically adiponectin and I don't remember the other one. Okay, but it's not also involved. Yeah, it's not mentioned here, but it's something I studied yesterday. Anyway, so basically, usually a healthy human being, we're gonna have increased levels of adiponectin. Okay. So as we said, adiponectin is anti-inflammatory. It will prevent inflammation. It prevents problem. But when we have insulin resistance, what happens is adipose tissue, it's going to be triggered, and then it will cause pro-inflammatory cytokines to be released, or the bad guys to be released, which is basically interleukin-6 and leptin. Okay. So you guys just have to know we're gonna have increased levels of شو اسمه So the pro-inflammatory cytokines, okay, they're the bad guys. They will cause basically, they will like exacerbate the issue and makes it worse, okay? Come on. The rest, يعني, I think خلاص we know it. إنه insulin resistance is increased lipolysis and production of free fatty acids. Okay. Free fatty acids, they will decrease the use of glucose. Okay. And they will contribute to hyperglycemia, and they will increase the deposition of triacylglycerides in liver. يعني you can think of it إنه عندنا a lot of free fatty acid, فبصير في عندنا, it will make the hyperglycemia worse, and we're gonna have deposition of the fatty acids in the liver, which is called hepatic steatosis, and it's one of the basically like symptoms or one of the manifestations of type 2 diabetes. In here, this explains the insulin resistance. You can see, guys, in obese patients, sorry, no. So in here we can see, okay. So in here we can see the insulin levels in blood, okay? So this is a normal patient. When we have normal amounts of basically insulin in the blood, you can see how it's like less. But obese patients, they have insulin resistance, so you can see that we have to produce higher amounts of insulin. And if you can look in here, the glucose levels in the blood are the same for normal and obese, almost, not 100% the same. But if you compare this to this, we can see that we have to have huge amounts of insulin to have a normal glucose levels in the blood, while in the normal, you see how insulin is like normally there. You get my idea? The idea is in obese patients, we're going to have insulin resistance. So we're going to have, the body has to compensate and secrete huge amounts of insulin just to keep the glucose levels in the blood as a normal patient. Okay? It's a compensatory mechanism. Well, I think it's clear. So in type 2 diabetes, the pancreas initially retains the beta cells, and then they will become increasingly dysfunctional and fail to secrete. This is what we said. لما الانسولين, لما the body requires more and more and more and more and more insulin, بيوصل لمرحلة إنه البeta cells, they're like خلاص, I can't anymore, and they just leave. And this is exactly what we're saying. شايفين عندنا insulin resistance, and it's caused by genetics, obesity, because of old age, because of inactivity. بصير عندنا hyperinsulinemia, impaired glucose tolerance. So basically, we have huge amounts of insulin for a small amount of glucose, and this will cause the beta cell function to خلاص. They're just like, I don't want to do this anymore. And they'll dysfunction, and we're gonna have type 2 diabetes. And we're gonna have like the complications are gonna start with the like the impairment of the beta cells, the macro and microvascular. But I don't think you guys discussed a lot of macro and micro. Yeah, sure, ask.
So diabetes type 2, is it like different for diabetes type 1? So it's not showing when like the pancreas or the beta cells destroyed to 80 to 90%, right?
Yeah. So basically, you never know.
We can like discover it earlier than type 1 diabetes.
Yeah. Not necessarily. It depends. Like the symptoms, in type 2, in type 1 diabetes, as we said, they'll just appear after 80 to 90% of the beta cells are like damaged. But in type 2 diabetes, I think we can discover it a bit earlier. But I'll tell you something. Usually after insulin resistance, but give it five years, the beta cells will start dysfunctioning. Hello? While in type 1 diabetes, after the autoimmune destruction, we have 10 years. 10 years حتى يصير عندنا like 80 to 90% of beta cells are destroyed. So I think, yeah, it is true. Type 2 diabetes, the manifestation of symptoms will start earlier than type 1 diabetes. Because in type 1 diabetes, it's not going to, I'm telling you, most of the time, patients will present when they have diabetic ketoacidosis, and this is like the most severe type. The body will reach a hypoglycemic state that is so severe. Hyperglycemic,
Okay,
sorry.
clear.
Hyperglycemic state that is so severe. Yeah. Now,
Okay, thank you.
you're welcome. These are the metabolic changes we said in hyperglycemia. Ketosis is usually minimal or absent. And I mentioned this because even in the presence of insulin resistance, we still have insulin. So we're not going to have ketogenesis in the liver, okay? So diabetic ketoacidosis, more common in, what is it called? Wait, I think my laptop is, okay. So it's more common in, what is it called? In type 1 diabetes compared to type 2 diabetes. Hello? Because as I said, we have insulin. We don't have complete diminution of insulin, okay? And then we're going to have low levels of HDL, and we're going to have dyslipidemia. And dyslipidemia means we're going to have a lot of fatty acids in the blood, okay? I think it's clear. And we mentioned these like on and on and on. وهي نفس this is literally the same as the previous one. The only difference is that we have insulin, so we're not going to have ketone production. Like on ketone buddies, we don't have ketone production. But we're going to have increased VLDLs and chylomicrons, and that's why we have the dyslipidemia. And yeah. Now, the treatment of type 2 diabetes, it's lifestyle modification. So we're going to reduce the weight, we're going to exercise, we're going to change the way that they're going to change their diet. And we can give them like hypoglycemic agents or agents that will decrease the hyperglycemia, مثل metformin. And it's really important. Like this drug is very, like, it's always used. حتى in pre-diabetic stages, they usually help in prevent diabetes by giving them a pill of metformin. وعندنا sulfonylurea. Now sulfonylurea, it's one of the drugs that increases insulin secretion. So we're going to have more insulin. So it will kind of help the insulin resistance. And thiazolidinode, whatever, it's very hard. Plus, it increases peripheral insulin sensitivity. So basically, it will decrease the insulin resistance, which will help. You get me? So the main thing to know is, no, we don't give them insulin. Relax. We ask them to change their lifestyle. We ask them to lose weight. We ask them to exercise. And we can give them like a couple of drugs that can help in decreasing the hyperglycemic state, which is basically metformin, sulfonylurea, and the rest. طبعا only in severe or advanced cases. And when we say severe or advanced cases, يعني we have extensive damage of beta cells, not the insulin. يعني إذا وصل هلا usually beta cell dysfunction ما بيوصل 80 to 90% like in type 1 diabetes. But let's say the patient is very old and he was diagnosed with diabetes at a very young age, let's say at 20 and he's like 80. فيمكن يوصل ل 80-90% of damage of beta cells. And this might cause basically he might need insulin therapy. But again, insulin therapy only in severe and advanced cases. Now we can see in here that we have a lot of complications of diabetes. In second and third year, you're gonna take microvascular or macrovascular. So micro يعني very small vessels, and macro اللي هن بالlarge vessels. And you can see إنه إحنا عندنا هون شيء اسمه premature atherosclerosis. So because of the hypertriacyl glyceremia, عندنا a lot of fatty acids, like extreme amounts of fatty acids in the blood. We're gonna have what is it called? We're gonna have predisposition to atherosclerosis. So basically, الفات خلص, where will it go? It will deposit in the arteries and so on. فبصير في عنا CVD, بصير في عنا stroke. هاي macrovascular. هلا المicrovascular اللي هو it happens in very tiny vessels مثل بالاي اللي هو retinopathy. Retinopathy is very, شفتوا كيف at the beginning of the lecture we said إنه diabetes is one of the most common causes of adult blindness. It's because of the retinopathy. If we did not prevent the diabetic retinopathy, or if we do not treat it, it might result in blindness. And then we have nephropathy, which basically is we have problems in the kidneys because of the increased secretion of glucose. And then we're going to have neuropathy. Neuropathy, they'll start to مثلا not feel their hands. They'll feel like tingling, or they will lose sensation على الآخر, especially in their foot. And that's why like diabetic foot is very, very common. Basically, patients might yani, need amputations because they literally cannot feel their, like they cannot feel their foot. فمثلا if they're injured or if they have like a wound or anything, they're not gonna see it. Yani, let's say they have a laceration on their foot, it's gonna get infected, and they're not gonna feel any pain or anything because of the neuropathy. And this infection might result later on into like basically gangrene, and we'll need yani, amputation and so on. So that's why it's really important to yani, like if a patient comes in with type 2 diabetes, you have to directly screen for all of this. You have to make sure that the retina is fine. You have to do like مثلا kidney function tests. You have to do neuro tests and so on. Huh? Um, okay, so there is no preventive treatment for type 1 diabetes. Yeah, because type 1 diabetes, as we said, it is autoimmune. So yani, no matter what you do, you cannot prevent your immune system from going down. I don't know. Like يعني خلاص, your immune system dysfunctions, you cannot prevent it. But type 2 diabetes, it can be significantly decreased by a regimen of medical nutrition therapy, weight loss, exercise, and aggressive control of hypertension and dyslipidemia. And if a patient has hypertension, if a patient have problems in their fat and so on, all of this can contribute into basically, what is it called? All of this can contribute into the, yeah, it can worsen the diabetes, but basically to prevent it from, like it can lead to diabetes. To prevent it from leading to diabetes, we have to control it properly. تمام? I mean, it's kind of easy. And this is a table where we basically compare both of them. So type 1, childhood or puberty. Type 2, frequently after the age of 35, but recently it reached the age of 20. So just say type 1, below 20, type 2, over 20. Diabetes, they usually have undernourished. They're going to be very lethargic. They're very fatigued. They're going to be very thin. While type 2, they're obese. Okay. Type 1 is less common than type 2 because type 1, we said autoimmune disorder, so it's not going to be as common as type 2, which is technically like genetic and so on. We said genetic predisposition is يعني meh in type 1, but in type 2, it's very strong. And هون we said the B cells are totally destroyed. Hon, they're just dysfunctioning. We have insulin resistance. No. Ketosis in type 1 diabetes, it's so common that basically it's, as I said, the patient will most probably like present with ketosis or DKA. And type 2, it's really there. Insulin is absent or low when it's high early in the disease because of the insulin resistance and because of increased formation of insulin. But then after a long period of time, it's going to be low. Ketoacidosis is an acute complication. Hyperosmolar hyperglycemic state is acute in type 2. Hypoglycemic drugs, type 1 diabetes, they don't help really at all يعني الصراحة. But in type 2 they do. And treatment, we said insulin for type 1 and for type 2, diet, exercise. No. Do you guys have any question? في لسه هاي. في any question about type 1 or type 2 before I go to the last one اللي هو gestational diabetes? Gestational. As a matter of question, I'll move on. So basically, in gestational diabetes, it's called gestational. So it happens when we have basically when a patient is pregnant, all right? But what happens is, during her pregnancy, she's gonna have hyperglycemia, and this hyperglycemia can affect her because she might have like diabetes after her birth. Or it might affect the baby كمان إنه like if we do not control the diabetes اللي هو gestational diabetes, it might cause a lot of defects for baby. One of the main consequences of the diabetic gestational diabetes is fetal macrosomia, or basically the baby is going to be like really huge, like it's way larger than average, like as you can see here. But that's it. Just know that gestational diabetes happens when a patient is pregnant, and we have to treat it right away, and we have to control the hyperglycemia. Other than that, it can cause it would really harm the fetal progression and growth. Yeah, and you have to know fetal macrosomia, which is just basically a huge baby. Anyways, I have 3 more questions. Okay, and we're done. So, what do you think the answer is here? I'll read the question. So, in type 1 diabetes, we have hyperlipidemia. Okay, the best explanation for that is that the level of an enzyme important for fat homeostasis is reduced. Which one is that? So, why do we have increased? Exactly, because lipoprotein lipase is not stimulated because insulin is decreased. Perfect. Okay. So a patient has poorly controlled type 1 diabetes and they exhibit elevated plasma glucose concentration. The increase results in part because in the absence of insulin, there is a lack of induction of glucokinase in which of the following organs? Yep, D, the liver, because glucokinase is going to help the liver to sense the amount of glucose that is there, okay? And then it will basically send the pancreas, and pancreas secrete insulin, or pancreas secrete glucagon, بس معنى بالliver glucokinase, then it's not gonna help, okay? Next, last question. So in type 2 diabetes, we retain some level of pancreatic function. طيب, this fact explains why they rarely manifest which of the following symptoms that is typical in type 1 diabetes. I get why you chose polyuria, because we said that no, they're not as common. Like the 3, polyuria, polydipsia, and polyphagia, are not as common in type 1, in type 2, sorry. But we said no, one of those things, we said no, it rarely happens in type 2 diabetes. Like super rarely. Yeah, see, exactly, ketoacidosis, because we do have insulin, and the body is not going to be pushed into forming ketones because of the presence of insulin. But ketoacidosis is the right answer. Anyways, this is it, guys. If you have any questions, I included my, what is it called? My contacts in the beginning here. You can email me or send me a message on WhatsApp. Ooh, if you have any more questions in here, guys, tell me. It's relatively a very easy topic. Ooh, I feel like it's very important for the future. Yani. You'll forever keep on taking it, even if you مثلا become whatever kind of specialty you will become, inshallah. You have to know the basics of diabetes and know how to treat it, and know the complications. No, inshallah, in 3rd year you're gonna take it in more depth, and it's more fun. Yani, when you understand that, oh yeah, this complication or this symptom happens because of this. And I tried as much as possible to kind of explain it to you guys, even if it's not included. But yeah, anyways, I wish you the best of luck. I wish you the best of luck in MOL. Inshallah, you all are going to ace it. We'll get straight A's, ya Rab. Oh, good luck in renal, and I'm gonna miss you guys. It's my last spell session. I'm so sad. Thank you guys. I'm gonna miss Paul so much. مكانه خلاص بكفي بكي. Karama? Is Karama still here? I think she is.